So we have a gentleman here who came 2 days ago with STEMI of the inferior wall. The patient had a totally occluded right coronary artery, so we have no
Next
potential
slide,
conflicts for this patient. And the patient had a history of dyslipidemia, mild dyslipidemia. Angiogram demonstrated occluded RCA, which was the culprit of the STEMI, and diffuse multifocal disease and calcified lesions in the left system. May I have the next slide, please? So this is the schematic diagram of the anatomy. So very complex disease globally. May I have the next slide, please? And this is what we did for the RCA. So calcified disease occluded in the mid segment. We recanalized it. We use the technique when it's calcified and it's acute when we don't necessarily want to image immediately. We use a non-compliant balloon with a 1-to-1 balloon to artery ratio, and then use orthogonal projection to make sure the balloon is fully inflated. And then if this is the case, we continue on to stenting. And we finally had a very good result. So as far as the clinical algorithm, for the non-infarct related artery lesions, we suggest that we go by angiographic severity. If it is intermediate, we definitely promote IFR, FFR guided PCI for those lesions. If it is clearly severe, we promote angiographic imaging guided PCI. And if it is a CTO, this is a special consideration, but we promote default OMT to start with. So normally here at the Heart Institute, the non-infarct related artery are typically performed as a stage procedure during the index hospitalization. And this is the case for this patient. As I mentioned before, this patient came in with a STEMI about 2 days ago, so 48 hours ago. And now we're planning on doing an angioplasty.
Yeah.
Okay, so this is the result of the RCA. It remains a good result in the proximal part where it was actually stented. We have still some diffuse disease in the PDA, but this was not addressed and will not be addressed as of now. You have the next image, please, la prochaine séquence. So this is the left system, which is the target for today. We have very severely calcified lesions, both in the marginal branch and the marginal branches, I should say, distal circumflex. We also have LAD, which is severely calcified. We can definitely see it by looking at the angio. It is also some ectasia, so very complex disease. Prochaine projection, s'il vous plaît. So we have an extremely tight lesion of DLAD after the diagonal branch. It is also severely calcified, again with some ectasia. Prochaine diapo, s'il vous plaît. Prochaine run, s'il vous plaît. So you can also appreciate that the diagonal branch is also severely diseased and narrowed. So our evaluation is that most of these lesions would be more than 70% angiographically speaking by eyeballing. So we would perform immediate angioplasty of the LAD and diagonal and the distal marginal. But we would also evaluate the major marginal branch by physiology if we can, because it is not necessarily 70%. So we decided we were going to go ahead and do the angioplasty of the LAD, calcified, very calcified. We wanted to do OCT, so we tried to open the vessel a little bit with a 2.0 non-compliant balloon, and we perforated 2 of these balloons, showing us that this was extremely calcified superficial calcium and could not dilate this. So lithotripsy would not be an alternative as of now. So we switched plans. We went to Rotablator. So we are going to do a switch from the BMW wire we had in place for the roto wire. We use the roto floppy, and we're going to use a 1.5 burr to actually do this. So we're going to do this live for you, and we're going to perform this, and then we're planning on doing a mini crush stenting procedure for the diagonal branch. So we are using in the roto flush is my own recipe. It's been the same recipe for a long time. I use verapamil, nitro, and heparin in the flush. I'm not using roto flush. I'm not using the roto solution because I do believe that we embolize enough. We don't need to embolize fat when we do this procedure.
Yep.
So as we go in, for those of you who don't do Rotablator so often, neither the guide catheter nor the wire can actually move as we go in. We're using a 1.5 burr. I typically don't go under 1.5. I think it's enough. So Jemina is going slowly. I'm following her. The wire's coming back just a little bit, so I'm going to let it go just a little bit as she goes in, but I'm going to hold it. You cannot maneuver the wire when the system is in place. We should see the burr soon.
It's coming. The wire is coming back.
Okay, hold on for a second.
Yeah.
So now that we have pushed this a little bit, I'm going to just make it go ahead a little bit. Okay, advance.
Yeah.
Okay, hold on. Okay, so I just set it a few times so that we don't have surprise. It doesn't jump. Okay, so for now, I think it's, I prefer myself to do something different than most. I most prefer the pecking technique. I prefer to slowly oppose the burr to the lesion and go slowly in a controlled fashion through the lesion. This is what happened here. It went fairly well, no major deceleration, and the first pass went through nicely. So now we're going to see if there is a no reflow dissection or something else. So now we're going to try a non-compliant balloon. To see if we can actually crack the lesion. If we cannot, we will use lithotripsy to complete the work. Of course, now that we have, we're quite confident that lithotripsy can actually go in, and we've already done Rotablator. We don't need imaging at this point. Just to see whether the balloon expands or not will be enough. This will be the ultimate test. So we'll do it as elegantly as we can. So we're going to use again the microcatheter to make the exchange to the standard PCI wire, which is the BMW, our so-called workhorse wire.
Quite smooth.
So very smooth. Okay, that's fine. So we'll stop there, remove the roto wire, change it for the BMW. Okay, merci. Exchanging the wire to the workhorse wire. So we'll bring this back.
Yeah.
Now we're going to hydraulic this out. Okay, so when the system is in full equilibrium, we will just make sure that we will remove air, no air in the system, and we will go up to about 14. And this is going to come out. Catch it, please. Okay.
Yeah.
Okay, so maintain it to 14 and it comes out nicely. Okay, we got it. Okay, let's prendre l'autre BMW, s'il vous plaît. We're going to protect the diagonal now because we're planning on inflating balloons now. So we will try to protect the diagonal. Okay, so now that the diagonal branch is protected, we will identify this wire by using the torquer, and we will bring down the non-compliant balloon. We use the
3015
30 to see really well if it's inflated or not. And as I mentioned before, we will use orthogonal projections to make sure that this is well open. We're using a non-compliant balloon in order to go up in pressure, make sure this is well open.
That's open.
Yeah, I think that's open. Off. Okay, so that's fine. We'll go cine.
Ready.
Okay. Cine.
Yeah.
Okay, well, this went flying in.
Yeah.
So as you see, these multi-vessel disease patients are not necessarily always easy to perform, but because they are stage procedure, this is clearly an advantage for us, because if we would have tried to do this during the acute procedure, it would have made things much more complicated.
Mhm.
And to be fully honest, I don't think it would have been appropriate.
Mm.
So I'm strongly in favor, and I promote whenever possible that we should do stage procedures, because I'm expecting the result on the LAD to be optimal. And I definitely do not want to have a suboptimal result in the LAD. So I would have done it during the acute procedure, would have made it complex.
So the 2015 is the longest we've got.
No.
Yeah.
So again, because of the calcifications, I'm using non-compliant balloons even to pre-dilate.
Passed quite nicely. Yeah.
Yeah, went in, and we could feel the calcification. Okay, test.
Yeah.
Going to make sure we're not missing the lesion that we are aiming for. So I think so we need to go a little bit distal to this bifurcation in the middle portion. It's test.
Yeah.
We're going to go up to here. Okay,
On.
I think we can go up to 20 would be good.
Yeah, 20. Nice.
Okay, well open. This is not severely calcified by the angio. Off. Here is where it is severely calcified though. Okay, on 24.
Got.
I'm not sure it's opening up proximally, yeah?
Yep.
I'm going to keep it up for a little bit, see if it's going to open up more. It's not opening up, huh?
No. It's a calcium.
So we have two options, either go down again with the roto to this branch, but we would need to leave the LAD, the LAD without a wire, which I don't necessarily like. So we may try to go up with Shockwave in the diagonal branch.
A 2.5 Shockwave. Off.
I tend to go to a slightly larger balloon to artery ratios with the Shockwave balloon, in the sense that whenever you use a too small a balloon, you run the risk of not being able to perform the actual fracturing of the calcium. So my experience is that you need to go with slightly larger balloons rather than smaller balloons.
I have it.
C'est bon? Ça a l'air
c'est
bien?
bon.
Oui. Okay, the profile of this balloon, of course, is by no means the best you will ever see. So it would be interesting to see if we can slide this in the diagonal branch. So coming in.
Okay, thanks, Tom.
So ACT is 296. We appreciate that. We like it to be as high as possible. Okay, so it was actually put into position nicely. J'aurais besoin de voir les images du.
On peut tourner ça, s'il te plaît? Le Shockwave, là.
Okay, go on to.
4?
Go to 6.
Yeah.
Okay, so we're up. So we're giving the treatment right now. Seems to be well open.
Yeah.
I think so, yes. We'll go a little bit further down the vessel.
Do you want me to?
Yeah, off. Okay. Inflate again.
Yeah, 6.
Seems like it's opened up again nicely at this point. Off. So much better than our
Much
previous.
better, yeah, for sure.
So we're sort of happy with that. A little bit further down again, if we can.
The wires.
Yeah, so some resistance here, of course. So it seems that the resistant lesion is a bit more proximal. So we're trying to be careful while pulling that the wire does not go too far down.
Yeah.
Same with the guiding catheter. Okay, on it, 6 again. When we're going to use all the, even 8 if you can. Increase a bit the pressure to 10.
Okay.
That's nicely open. Off. Okay, so we will see what this looks like angiographically. Why don't you go up here a little bit in the LAD?
10?
Yeah. And yeah, we're going to give the shocks.
Okay.
Nicely open.
A bit of a dissection in the middle,
yeah. Okay, so our goal now will be to stent the diagonal first, because I don't think I can actually come in with a stent in the distal in the diagonal branch afterwards. So I'm going to use a 2.0 by a 2.0 stent. So I'm going to use Onyx 2.0. Est-ce qu'on a un 2.0 le plus long qu'on a? Qu'est-ce que c'est? So this went down very nicely. Test. Perfect.
Not bad, yeah.
Now we need to choose the actual projection that will show us the best possible projection to see the origin of the ostium of the diagonal branch. Fait qu'on va aller en OAG, s'il te plaît. Okay, my goal here, my strategy and technique will be the mini crush stent. So we're going to go up now. Go up to maybe
12.
Yeah, 12 is fine. So to me, it looks nicely open.
Yeah.
Okay, off. Now go back a little bit up in the LAD. On 18, please. Remember, this is a 2.0 stent, so at 18 atmospheres.
Mm-hmm. 18.
Okay, off. Okay, so I'm going to leave this balloon inside the stent in order to allow me to come down in the LAD with a non-compliant balloon. Je vais prendre un 3.0 par 15 ou 20 de long, s'il vous plaît, non compliant. And the goal here would be to advance a non-compliant balloon. If we are in place, we're going to remove the wire from the diagonal branch, crush the stent, come down with the LAD stent, and then do pot technique, rewire, and then going and performing a final kissing inflation and a pot technique at the very end for the proximal AD. The balloon left inside the stent will help us to try to maneuver around the strut of the diagonal branch that may be sticking out, or hopefully sticking out a little bit in the LAD. But we're going to leave this in a neutral position, and then we're going to go in with the non-compliant balloon in the LAD and see how it behaves.
We'll just need another inflate.
So we're going to use a very long stent. We have 48 synergy stent. This is what we're going to try to get in place. We'll see if we have the... Okay, so we're happy with what we see for now.
Yep.
$2,75,48, c'est bon.